Hi, my name is Philip Friesen. It is June 8th, 2021. This is Case Connections for Unit 4, Case Number 1. Ammonia is transferred to the liver by way of two non-toxic amino acids, glutamine and alanine. In peripheral tissues outside the liver, glutamine synthetase condenses ammonia and glutamate to form glutamine, which can then be shuttled to the liver to provide ammonia, nitrogen for nucleotide synthesis, and substrates for gluconeogenesis. In the liver, glutamine is deaminated twice, once by glutaminase and then by glutamic dehydrogenase. Disposal of excess nitrogen goes through the urea cycle. Urea can then be excreted in the urine. The patient in case 1 is having a buildup of ammonia which is toxic. The buildup of ammonia is most likely due to a deficiency in the urea cycle. Her labs show elevated levels of orotic acid and normal levels of citrulline. This indicates dysfunction in the enzyme that catalyzes the reaction of carbamoyl phosphate and ornithine to citrulline, ornithine transcarbamylase. Carbamoyl phosphate can enter an alternative pathway in the synthesis of pyrimidine. It is in this pathway that orotic acid is formed, and because of the deficiency in the other pathway, excess is produced. Arginine, under normal circumstances, is a non-essential amino acid. However, in this case, it is produced in the urea cycle downstream to carbamoyl phosphate. Due to the deficiency in ornithine transcarbamylase, arginine production will be hindered, causing it to become an essential amino acid. On to case number 3. In this case of gout, the most likely cause is the increased fructose consumption and a decreased excretion via the urine. The reason for this is that uritate is high in plasma, yet urine analysis shows a decrease in uric acid output. The patient in question, 47 years old, did not begin to show signs of gout until recently, when he began to consume large amounts of fructose. Fructose consumption has been linked to increased purine production and in turn increased uric acid production. It is likely that if the patient had issues with overproduction of purines or purine salvage, he would have had other symptoms because these diseases can cause many other problems and in most cases manifest earlier in life. Fructose is rapidly phosphorylated in the liver by fructokinase to fructose 1-phosphate. It is at this point where the rate-limiting step of fructose metabolism occurs. Fructose 1-phosphate is then metabolized to glyceraldehyde and dihydroxyacetone phosphate by aldolase B. Aldolase B has a low affinity for fructose 1-phosphate and is also part of the glycolytic pathway. When large continuous quantities of fructose are consumed, inorganic phosphate will be stuck in the form of fructose 1-phosphate, halting the production of ATP. The lack of ATP production will increase the amount of AMP and will in turn cause downstream increased purine production. With an increase in purine production comes an increase in uric acid production and possibly gout. The patient's gout is then caused by an acute increase in purine production as well as a decrease in excretion as evidenced by his labs.